Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an unconditional educational grant from Case Farmaceutici Società Perazzoni.
This program is presented by Medscape Education Global.
Hello, I'm Mario Schiffer. I'm a transplant nephrologist from Erlangen in Germany with more than 20 years of experience in treating kidney transplant patients. And during my 15 years of consultant work at Hanover Medical School, also patients after liver transplantation. And I have a special research interest in support programs before and after transplantation to improve medication adherence and transplant outcome. And I would like to welcome you to this program titled One Size Doesn't Fit All, a practical guide on how to personalize tacrolimus-based therapy in transplant recipients. So join us for a 45-minute tour de force featuring a short introduction to tacrolimus-based therapy in liver and kidney transplantation, followed by expert-led presentations of 5 real clinical patient cases. So, in the beginning, I'd like to start to talk about the dilemma in transplant medicine. Obviously, if your immunosuppressive therapy is too high, there are problems with infections, renal failure, malignancies, and also metabolic complications. And on the other hand, if your strength of immunosuppressive medication is too low, there can be problems with rejection and transplant loss. So, just as a very brief recap, the modes of action of different immunosuppressive drugs are depicted here. So what you see is that when there is a stimulation of the T cell, there's activation of the calcineurin pathway, leading then to transcriptional activation and an auto-feedback loop basically with IL-2 production and then auto-stimulation via the IL-2 receptor. And also, then there's another mode with the purine pathway, with mTOR inhibitors and also IMPDH inhibition to inhibit purine synthesis, which then affects the cell cycle. And for each of these pathways, we have different strategies, how we would interfere with it to prevent expression of interleukin, then the signaling on the interleukin-2 receptor, and also then interfering with proliferation of a specific T cell clone via the cell cycle pathways. So if you look at the agents for maintenance therapy in liver and kidney transplantation, you see that both of the therapies are pretty similar. The only major difference is that not on a regular basis you will have induction therapy in liver transplants, but the maintenance therapy usually contains glucocorticoids, calcineurin inhibitors, anti-metabolites, or belatacept, for example, in the case of the kidney transplant. And in the liver transplant, you have glucocorticoids, calcineurin inhibitors, and also anti-metabolites. And for maintenance, it also depends largely on your center standard, how you dose patients over a longer period of time. So here you see the Sankey plot for the typical immunosuppressive therapy after liver transplantation. And what usually works out the best is a combination of calcineurin inhibitors and anti-metabolites. After liver transplantation, you also have a specific problem with mortality. And the mortality, as you can see here, can be based after the different timing amounts, after, like, let's see, 6 months, dependent on infections, on recurrence of the underlying disease, and also tumor recurrence. There can be de novo tumor happening, and also there's also a slight window of rejection therapy. So it's important to keep in mind that up to 25% of liver recipients develop also CKD, and that's an important problem after liver transplantation. And the typical malignancies after liver transplantation would be skin malignancies, lymphomas, tumors of the esophagus, which is mainly associated with the consumption of alcohol and smoking. And after kidney transplantation, in most centers all over the world, our standard immunosuppressive therapy based on the ELITE Symphony trial. And as you can see here, the combination that worked out the best is the low-dose tacrolimus arm that has the least probability of biopsy-proven acute rejections and also the best kidney transplant survival. And for the calcineurin inhibitors, with the tacrolimus, we have now 3 different possibilities how we can treat our patients. There could be the twice-daily immediate release tacrolimus. Then there is the extended release once daily and also a melt dose. And these would be the whole blood concentration curves over time. And what you can see is that for the immediate release tacrolimus, for example, you have a very high peak in the beginning, but for the low melt, for example, you have a more flattened curve. And that could have, depending on your patient, different advantages, as well as the advantage, for example, that is taken only once a day, which could also be an improvement of patient medication adherence. So this basically depicts the sequential first pass elimination. That is true for formulations. So you can see that there is already a first pass effect in the small intestine. And then once this is transported to the liver, there's another additional metabolism via CYP3A in the hepatocytes. So if you look at different segments of the intestine, you can see that the highest activity of CYP3A is placed in the duodenum. And this is actually where most formulations of calcineurin inhibitors are reabsorbed, while there is very less activity of CYP3A in the colon, and this is where most of the low melt dose tacrolimus is reabsorbed. And this translates into then the flat PK profile of the extended release with a more stable tacrolimus concentration over 24 hours, as you can see here from this trial. So there are pros and cons of once daily formulations. Pros is obviously, there's a better reabsorption and also bioavailability. And cons is that there is a longer wait for correct trough levels. And another pro is that it requires very often a reduced dosage because of this reduced first pass effect, reduced peak levels. You don't have to dose as high to reach the correct trough level. And that translates into less neurotoxicity and also potentially less nephrotoxicity effects. And then it's also important to talk a little bit about adherence or non-adherence to immunosuppressive therapy. And here are the 5 dimensions of the WHO for adherence. And you can see that this is really a mixed bag. So the patients need a lot of social support. They have also to have a certain trust in the therapy. Some patients have a fear regarding side effects. And then there could also be some comorbidities and depression. And all these factors you have to take into account when you talk about your specific patients for non-adherence. It's not just that the patient is not taking the drug. And especially in the early phase after transplantation, there's a very frequent dose adaptation necessary to reach the correct trough levels. And that is already a problem for the perfect adherence of the patients. So the patients need, in other words, a lot of support. And here you see different studies looking at the rate of non-adherence in kidney and liver transplant patients. And what you can see here is that it's largely dependent on the method, how you would assess the non-adherence rate. For example, we had done, when I was still at Hannover Medical School, a cross-sectional analysis of our patients where we had anonymized that the patient had to do a basis test. And also at the same time, we asked our colleagues in the office to assess whether they thought the patient would be adherent or not. And what you can see is that only 9.8% of the colleagues in the office would think that their patient is non-adherent, while 36% of the patients admitted themselves that they would not take their drugs as we expected them to. And the worst part about this is when you compare the two groups, there was an overlap of 0%. So that means that in a regular office setting without testing, we have no clue whether our patient is adherent or not. What are the frequent problems of non-adherence? Very often the patient does not really know everything about his or her immunosuppressive therapy, and even if the patients know that in the beginning, probably that knowledge is lost. So here we did a study, for example, where we had put in actually quite easy questions, and only 7% of the patients answered all of the questions correctly. So you have to test frequently whether your patient still knows everything about the medication or not. And then there are certain risk groups. Obviously, patients in emerging adulthood, when they are transferred from the pediatricians to the adult world in nephrology, this is the time point when we lose most of the transplants, unfortunately. So this is a special risk group that we have to take care of. And so we need specific transition programs for these type of patients. Also, a lot of patients really want to make everything right, but they can't because they have a cognitive problem. And you also do not recognize that immediately. You would recognize that more when you really specifically test it. And we did that also in a sub-study of one of our programs that we were running. And we were surprised that probably around 16% of the patients really had a cognitive problem. So these patients would need additional social support also to make sure that they would take their medication as we wanted them to. When do we have to test for non-adherence? And here in this study, you can clearly see that in the beginning, all the patients are very adherent, but it starts like around 6 months after transplantation when you are able to detect the first non-adherent behavior in these patients. So from 6 months on, you should start probably screening your patients. And with what should you screen? So the Basel assessment of adherence to immunosuppressive medications scale is actually quite handy for this, and it works very well also on a repetitive basis. You can do this depending on your patient's skills also, and make a self-assessment or do this interview-based. And there could be some advantages of once-daily formulations compared to twice-daily formulations. This study, for example, showed higher taking adherence with the prolonged release tacrolimus over time. And if you ask the patients, like this Spanish study here did, you can see that 71% of the kidney transplant and 62% of patients after liver transplantation, they would rather prefer to drop the evening dose if that is possible at all. So, in very broad terms, I've covered the main important aspects to tacrolimus-based therapy in liver and kidney transplantation. So please continue now to the next segment to learn from Dennis about the pharmacokinetics of tacrolimus across 3 different populations of kidney transplant patients. Thank you for listening.
Hello, my name is Dennis Hesselink. I'm a transplant nephrologist from Erasmus MC in Rotterdam, the Netherlands. And I've been involved in the care of kidney transplant patients for more than 15 years now. I'm also a consultant for our heart transplant program, and my research mostly focuses on clinical pharmacokinetics of immunosuppressive drugs. Now I would like to take you through 3 cases, and the first is kidney transplant patients that I will use to illustrate the consequences of fast tacrolimus metabolism. So this relates to a 45-year-old male patient born in Nigeria who developed end-stage kidney disease because of focal segmental glomerulosclerosis. And this patient is then admitted to our hospital for his first deceased donor kidney transplant, and you can see the HLA mismatched below, and this patient was non-sensitized. And I think there's 2 important questions that I would like you to think about, and the first one would be, what starting dose of tacrolimus would you prescribe? And the second is, what target concentrations would you aim for? Now, before we answer these questions, I would like to give you a little background. If you look at the package insert of tacrolimus, then the advice is to base the starting dose on body weight of the patient. And there is a certain range depending on the type of transplant, but in general, it is body weight based tacrolimus dosing. Now the thing is, the correlation between a patient's body weight and tacrolimus clearance is actually very poor. And this is a study that was published already many years ago. And you can see at 3 different phases after transplantation, there is a very poor correlation between a patient's body weight and tacrolimus clearance. And this is the same principle illustrated by a more recent study where, again, kidney transplant patients were analyzed and their body weight was correlated with their pre-dose concentration. So that was early tacrolimus exposure as measured by a trough concentration. And again, you see that there is hardly a correlation between a patient's body weight and tacrolimus exposure, and this is especially true for CYP3A5 expressors that are indicated by the dotted line here. So once again, this study demonstrates that dosing tacrolimus solely on body weight will result in overexposure in a considerable number of patients that are overweight or obese. And the second thing is, if you consider the target concentrations that we aim for, I think that most transplant centers will have their target concentrations in their protocols, but contrary to the belief of many physicians and surgeons, the concentration effect relationship for tacrolimus actually has been very poorly defined. And this is in fact the only study that compared 3 different tacrolimus concentration ranges and looked at the effect of these concentration ranges in relationship to rejection risk and the development of toxicity. So this was a study that was conducted in the mid-90s, and patients were targeted to 3 concentration ranges for tacrolimus. And you can see there was a low trough concentration which targeted tacrolimus to between 5 and 14 nanograms per ml. There was a medium trough concentration group and a high trough concentration group that was targeted to a tacrolimus trough between 26 and 40 nanograms per ml, which is a concentration that we now consider very toxic. And as was to be expected, the patients that were targeted to the highest concentration ranges actually experienced very little rejection, but they suffered from massive toxicity. And then there was another study that looked at the tacrolimus concentration effect relationship, and this was a study that was published by Israni and colleagues, and that was an analysis from the DCAF study. So this was a very large study, including almost 2,000 kidney transplant patients, and they then looked at the relationship between tacrolimus exposure and acute rejection risk by performing Cox proportional hazards analysis. And their main conclusion was that each 1 nanogram per ml decrease in tacrolimus pre-dose concentration was associated with a 7.2% increased risk of acute rejection. So obviously, if you have a very low tacrolimus concentration, that increases your chances of developing rejection, but that still leaves us with the question, what target concentrations should we then actually aim for? And this relates to an analysis that we performed ourselves, and this study included almost 1,300 kidney transplant patients that were participating in one of 3 large randomized controlled trials that were the ELITE Symphony study, the FDCC trial, and the OptiCept trial. And taken together, acute rejection occurred in 10.4% of patients. We found no association between tacrolimus exposure and the risk of acute rejection. So what should we do then? Well, I think in most centers, their target concentration ranges are based on the results of the ELITE Symphony study. And that was already referred to by Professor Schiefer. And this was one of the largest clinical studies that was ever conducted in kidney transplantation, including more than 1,600 patients randomized to 1 of 4 groups of different immunosuppressive regimens, and that you can see here. And to show you the main results, the group that was randomized to receive low-dose tacrolimus therapy actually did best, because these patients had the best kidney function, the highest eGFR, and the lowest rejection rate. And based on these studies, most centers now target their patients to the exposure ranges that were targeted in this study. And that is once again demonstrated here, where you can see the risk of rejection with the low-dose tacrolimus group doing best. Now the problem is, if you look at a randomized controlled study, especially a concentration range study such as this one, then there's always a difference between the targeted concentrations as defined in the protocol and what happens in real life. And what you can see here is that although in the low-dose tacrolimus group in Elite Symphony, the concentration range was between 3 and 7 nanograms per ml, in real life, most of the patients were targeted to a concentration that was very close to the upper limit of the concentration range. So in fact, this was not truly low tacrolimus exposure. Now, one of the important aspects of tacrolimus therapy, and that is something that holds true for all neurotherapeutic index drugs, is that we perform therapeutic drug monitoring. So we start a patient on a dose, and in the case of tacrolimus, that is usually based on a patient's body weight. We start the therapy, and then we measure the concentration of the drug after a couple of days, ideally once the drug has reached steady state. And what you can see here is that a number of patients will be on target, but many patients will either have supratherapeutic or toxic concentrations, and another number of patients will have subtherapeutic concentrations that might be ineffective. And this is a study that was performed by our group, and what you can appreciate here is that roughly 1/3 of patients was on target after body weight-based tacrolimus dosing at first steady state, meaning that 2/3 of the patients were either too high or underexposed. So I think we can do better, and one of the things that I believe in is that we can dose tacrolimus using dosing algorithms. And to understand that, it's important to realize what actually determines the pharmacokinetics of tacrolimus. Importantly, there's CYP3A4 and CYP3A5 genotype, but there's other factors including drug-drug interactions, body composition, age, ethnicity, and the composition of the blood. And if you take all these factors into account, you can create dosing algorithms, and this is just one example demonstrating that principle. And then you can use that algorithm to predict the dose of an individual patient. And this is again from a study that was performed by our group, and now you see in orange what would have been the starting dose if we had based that on the body weight of a particular patient. But for this study we did not. We based that on the algorithm, and then this is what you get in the blue line. And I think this very clearly demonstrates that body weight actually correlates very poorly with the dose a patient should receive. As you can appreciate that many patients require higher doses, whereas others require lower doses, something that would not have been happening if you would have stick tightly to the body weight-based dosing principle. But luckily, even if you end up being under or overdosed, by use of therapeutic drug monitoring, you can rapidly correct over or underexposure, and in the end, all patients will get to their designated targets. The problem is that will take time, and that during that time, patients may be under or overexposed and experience rejection or toxicity. So I think we can do better, and that we should be using algorithm-based dosing to get patients on target as fast as possible. And then we should be continuing using computer-assisted algorithms, not only to get a patient on target, but also to keep these patients on target as long as possible. One other thing that is important is so-called dried blood spotting. And this is a technique where patients are sampling themselves at home. They collect a drop of blood on a piece of filter paper or a collecting device, and that allows you to sample at home, send the paper to the hospital pharmacy for the determination of the concentration of immunosuppressants as well as kidney function. When thinking about this patient, this fast metabolizer phenotype patients, I think it is important to consider the formulation of tacrolimus we want to prescribe. And there is now a formulation of tacrolimus out that is called melt-dose tacrolimus. And what happens is that by using a very sophisticated procedure, tacrolimus molecules are sprayed onto a matrix, which is then coated into a tablet, and that will result in a higher absorption of tacrolimus. And that is depicted here in this study, where 3 different formulations of tacrolimus are compared, and in the blue line you can see the melt-dose tacrolimus, which has a flatter pharmacokinetic profile compared to twice-daily or extended-release tacrolimus. And this is important because if a patient with a fast metabolizer phenotype is transplanted and you prescribe tacrolimus, there's a large chance that this patient will have a trough concentration, or Z0, that is below target. And if you then increase the dose in order to get to the desired trough concentration, the Cmax will also increase, and also the AUC, or the total exposure to tacrolimus, will increase. So you will not only titrate a patient to the desired trough concentration, but you may also very well increase the total exposure to tacrolimus, increasing the chances of a patient developing toxicity. And the formulation is also very important because the melt dose tacrolimus is absorbed more distantly in the small intestine. The effect of CYP3A genotype is actually very much smaller compared to the standard tacrolimus formulation. Now, the concentration dose ratio is the trough concentration divided by the required daily dose. And this dose requirement is a measure of clearance phenotype. So the larger this ratio means that a patient needs less tacrolimus to attain a certain target concentration, and vice versa. And therefore a lower concentration dose ratio will also mean a higher peak concentration. And this is important when you consider clinical outcomes. So this was a large study from France, the Tomato study, in which a little over 1,000 kidney transplant patients were analyzed for death-censored graft survival. And these patients were then divided into 3 groups based on their metabolic phenotype by calculating the concentration dose ratio. Now, importantly, the patients who had the highest metabolic phenotype, so those were the fast metabolizers, actually had the worst death-censored graft survival. And it's not sure why that happened, but it may relate to tacrolimus nephrotoxicity. So coming back to our patient, I think I would ideally prescribe a dose that was based not so much on body weight, but was calculated using a dosing algorithm. Now, since this patient is likely to have a fast metabolizer phenotype, I would prefer melt dose tacrolimus in order to increase the absorption of the drug. And I would target maybe slightly higher concentrations than standard, because this is a relatively young patient that may be at an increased risk of rejection given his ethnicity. So I thank you for listening. Now, for the second part of my talk, I would like to illustrate the principles of kidney transplantation in the elderly. So this is a female patient that was 75 years old and developed end-stage kidney disease because of diabetic nephropathy. And she was admitted to our hospital to undergo her first living unrelated donor kidney transplantation. And when you think about transplantation of the elderly, there are some markedly important differences compared to younger patients. And the first important thing to consider is that in general the rejection risk of elderly is lower compared to younger transplant patients. And there have been quite a few studies that investigated rejection risk in the elderly as compared to younger, but I think this is one of the best studies that is out there, and that was done by Stefan Tullius and published already many years ago. And what you can see here in the blue line is the age of the recipient and the risk of developing rejection. And what you can see is that with increasing age of the recipient, the rejection risk actually goes down. So the higher the recipient, the lower the chances of this patient rejecting the graft. On the contrary, the age of the donor is positively correlated with the rejection risk. And the higher the donor is, the higher the chances the recipient will reject that graft. So it is very much the interaction between donor and recipient age that determines the rejection risk. And this has been illustrated in other studies, and this was a study from the Netherlands where you can see the risk of developing antibody-mediated rejection according to age. And what you can see here in the red line is that the elderly have a lower risk of developing antibody-mediated rejection compared to younger kidney transplant recipients. So as I pointed out, rejection risk is lower in the elderly, which has to do with immunosenescence. And the other principle in elderly is that they have an increased risk of dying from infectious disease. A third important thing to consider is that graft loss is a relatively rare phenomenon among the elderly. And then there's some other considerations when considering transplantation in the elderly. Elderly are more likely to receive a kidney of lower quality. In Europe, we have the Eurotransplant Senior Program. And finally, elderly are more prone to calcineurin inhibitor-mediated nephrotoxicity. So I think we should rethink our immunosuppression in the elderly. And I think that we should go from prevention of acute rejection, which has been the paradigm over the past 50 years, to preservation of kidney graft function and preventing over-immunosuppression and infection-related death. And when you then consider the pharmacokinetic changes with increasing age, there's many things that change if a patient gets older. So the advancing biological age leads to physiologic changes, including changes in body composition, liver size and liver blood flow, protein binding, etc. And that will all lead to age-related changes in absorption, distribution, clearance and excretion. And this was illustrated in this study, again from the DCAF study headed by Dr. Jacobson, and they compared the pharmacokinetics of tacrolimus in young, middle and older kidney transplant patients. They measured the tacrolimus pre-dose or trough concentration and calculated the corresponding dose and then concentration to dose ratio in the first 6 months after transplantation. And these are their main findings. And what you can see here is that elderly were actually targeted to the same trough concentrations as younger and middle-aged patients. But they required significantly lower doses of tacrolimus to get to that target concentration. And that, of course, leads to marked changes in concentration dose ratios, with elderly requiring the lowest doses of tacrolimus to get to a certain exposure. So elderly have a slower tacrolimus clearance, and what's more, they are also more susceptible to the pharmacodynamic effects of tacrolimus. And this is something that has not been investigated very well, but there are some studies from animal and ex vivo studies that demonstrate that elderly are more susceptible to the pharmacodynamic effects of tacrolimus. But the problem is that there are very few immunosuppressive trials that were designed specifically for elderly transplant patients. Now, I hope that will change in the very near future, because as we are talking, there is a Dutch-Belgian trial on the way. It's called the Optimize trial, and it stands for Open Label, Multi-Center, Randomized Trial comparing standard immunosuppression with tacrolimus and mycophenolate mofetil with a low exposure tacrolimus regimen in combination with everolimus in de novo renal transplantation in elderly patients. And this is the design. So this is a randomized control study where we actually compare two tacrolimus exposure ranges. And the good news is that the inclusion already started in September 2019, and that we are now in the follow-up as inclusion was completed in April 2023. So going back to the patient, I would be very cautious to give this patient the standard tacrolimus dose, because she's likely to have a low risk of rejection. She was likely going to be a slow metabolizer, that is at increased risk of tacrolimus toxicity, and therefore I would be on the cautious side. Thank you. Now, the third case is a male 27-year-old patient that developed end-stage kidney disease because of reflux nephropathy. And this patient lost his first transplant because of ABMR after recurrent T-cell mediated rejection that may have been related to non-compliance. And he's now admitted for a second deceased donor kidney transplant. And the question is, how would you go about dosing tacrolimus in this particular patient? Now, I think one of the things that should be considered when retransplanting a high immunological risk patient is the so-called tacrolimus intrapatient variability. And what we do here is that we move from inter-individual variability, which is the variability in tacrolimus pharmacokinetics between individuals, and then focus on the variability of tacrolimus within an individual over time. And this is to illustrate that point. So in the right side of the figure, you see the tacrolimus exposure in two individual patients. And one patient, the one with the open circles, actually has very stable tacrolimus concentrations over time, whereas the second patient, patient B, fluctuates. And this patient goes from high exposure to low exposure and back again. And that is without the dose being changed. So these are not alterations in tacrolimus exposure because the physician changed the dose, but these are changes while having a stable tacrolimus dose. And I think this is important, and this is from a large study that was published some 8 years ago. And here you can see the graft survival of patients having a high versus a low tacrolimus intrapatient variability. And what you can appreciate from this figure is that patients that have a high variability do worse in the long term. And that may relate to them having tacrolimus concentrations that are below the target, increasing their risk of rejection on occasions, whereas they may also be overexposed at certain time points, leading to tacrolimus nephrotoxicity. And I think in the end, that combination of over and underexposure puts them at risk for developing chronic irreversible injury, which causes increased transplant loss. And there have been other studies looking at the effects of a high tacrolimus intrapatient variability. This was a study from Spain where they looked at the incidence of de novo donor-specific anti-HLA antibody formation. And what you can see here is that the patient who had the highest intrapatient tacrolimus variability were at increased risk of developing DSA. So a high intrapatient variability associates with poor long-term outcomes. And the question then is, what can we do about it? Well, I think one of the reasons why certain patients may have higher fluctuation in tacrolimus exposure over time is actually non-adherence. And we may consider them switching to a once-daily tacrolimus formulation. So these are the findings, the main findings of the Admirat study that was conducted in Belgium. And what happened in this study is that patients were switched from immediate twice-daily tacrolimus to the once-daily tacrolimus formulation, and they then studied the adherence. And what you can appreciate from this figure is that when patients were switched from the twice-daily to the once-daily tacrolimus formulation, their adherence increased. So this, I find, a very important study that demonstrates that switching to a more simple medication regimen will increase adherence and probably long-term transplantation outcomes. The question then arises, if a once-daily tacrolimus formulation improves adherence, what happens to intrapatient variability? And this was a Dutch study that was conducted by Bunthoff and colleagues. And in this study, patients were all on immediate release, twice-daily tacrolimus, and they were then randomized in a crossover fashion to continue immediate release tacrolimus for a certain period of time and then switch to a once-daily tacrolimus formulation, or they were switched from the immediate release tacrolimus to the once-daily tacrolimus formulation and then back again to the immediate release tacrolimus. And patients underwent a second randomization comparing the two once-daily tacrolimus formulations that are now marketed. In this study, 102 patients were included, and what we observed was, like the Belgian study, that the intrapatient variability lowered after converting to once-daily tacrolimus. So, switching to once-daily tacrolimus lowers your intrapatient variability, very much likely caused by increased adherence. But there may be some other biological phenomena at work here as well. However, we did not observe any differences in the intrapatient variability between the two once-daily tacrolimus formulations. So from this study we concluded that switching to a once-daily tacrolimus formulation is beneficial, but that it doesn't matter which of the two formulations you choose. So going back to this patient, I would consider very strongly to start this patient on a once-daily tacrolimus formulation, and I leave the choice of the formulation to the audience. And this was all from me in terms of pharmacokinetics of tacrolimus in different populations of kidney transplant patients, and it is my pleasure to introduce next my colleague Marina Beringer, who will present 2 cases on liver transplantation. Thank you for listening.
Hello, I'm Marina Berenguer. I'm a transplant hepatologist from Valencia, Spain, with about 25 years of experience in treating liver transplant patients. And I have a special research interest in transplant outcome based on gender and the effect of immunosuppression on transplant outcomes. And I will use a couple of cases on liver transplant recipients to illustrate some of the specifics of immunosuppression in liver transplantation. And because my previous speakers have highlighted many general concepts on immunosuppression, and in order to avoid redundancies, I will not touch upon these specific aspects such as intrapatient variability, adherence, and I will focus on the specificities of immunosuppression in liver transplantation, particularly the differences between immunosuppression in liver transplantation and in kidney transplantation. And in fact, in liver transplantation, the outcome in the short term is excellent. It's well known that the liver is an immune privileged organ, and it's really rare that our patients die from rejection-related complications or immune-mediated complications. And in fact, most of our patients will die from systemic complications in the mid-long term that are mostly related to over-immunosuppression, among other factors. And this is likely to become even a more important issue as the landscape of liver transplantation, I would say also kidney transplantation, is changing, with recipient phenotype changing such that our patients are becoming older, they have increased obesity rates, they have increased number of comorbidities. In terms of the liver transplant indication, we have less HCV and we have now much more metabolic associated liver disease, more alcohol, and also we have more expanded oncologic indications. All these factors that overall are associated with are very important for liver transplantation because they really impact the long-term outcome in terms of cancer development and cardiovascular complications, which overall, as I mentioned before, are the major reasons of losing our patients and our grafts in liver transplantation. It's also important to understand that this also has implications for women particularly. Women are increasingly being transplanted for metabolic associated steatotic liver disease. And we know that women are disadvantaged in accessing liver transplantation. And this is related to several reasons. Among them, women are shorter. Sometimes it's more difficult to really find adapted organs to their sizes. Very importantly, they have less muscle mass, and this results in less creatinine levels. And creatinine is a very important part of the model score, which is the score that we utilize to prioritize our patients in the waiting list. Fortunately, there's a search for new models that try to find a solution to this disadvantage for women. And there are now two new models, the GIMA model and the MEL 3.0 model, that are incorporating some new factors, such as sex, to avoid these discrepancies in access for liver transplantation. It's important to validate these models in many countries. We've tried to validate the MEL 3.0, which is already in use in the United States, but had not been validated in other areas of the world. And in fact, in our setting, it is better than the MEL score, but not much better than the MEL sodium score. So we will need to continue evaluating these new models to improve the access to liver transplantation for women and other groups that may also be disadvantaged right now. So I'll present my first case. It's a woman with metabolic associated steatotic liver disease. On top of mast cell cirrhosis, she developed hepatocellular carcinoma, which required liver transplantation. As many of these patients, she had several comorbidities, obesity, arterial hypertension, diabetes. She had a preserved liver function, and she received a DBD organ, 50 years old, and was initially immunosuppressed with once daily tacrolimus and mycophenolate, trying to adjust the dose to achieve a trough levels between 7 and 10. The first thing I'd like to highlight is that if we consider that about 30% of our population has metabolically associated steatotic liver disease, that about 5% of these will develop inflammation and necrosis and steatohepatitis. And among these, about 20% will progress to cirrhosis. This makes about 3 million people in the US only, which will require probably a liver transplant because of muscle-related cirrhosis. These are huge numbers, and unless the new drugs that are coming along really decrease this burden, this may be a significant wave for our transplant waiting lists. So this patient, unfortunately, had progression after transplantation on liver ultrasound of steatosis. She went on from no steatosis in her first 6 months post-transplantation to severe diffuse steatosis at 2 years post-transplantation. And by the 5th year post-transplant, she already had some discrete heterogeneity on her ultrasound, suggesting that there may be development of cirrhosis. At 6 years, she had already irregularity in the surface of the liver and splenomegaly consistent with graft cirrhosis, and this was confirmed with elastography. So generally speaking, if we look at the literature, the post-transplant outcome of these patients is quite similar to the non-muscle-related indications. However, most of the studies have looked at the outcome until 5, 6, 7 years post-transplantation and have not followed their patients for longer follow-ups. And if we look at the cause of death in this patient population, the major cause of death is oncologic complications and cardiovascular diseases. These, in fact, are the same cause of death as in the non-muscle population. But if you look at the long-term follow-up of these patients, the risk factors to develop steatohepatitis increase significantly over time. And it's really after 10 years that we start to see the impact of these risk factors on the graft. And these risk factors, arterial hypertension, diabetes, obesity, are somehow related to the immunosuppressive drugs that we are utilizing in liver transplantation. And in addition, we need to also consider that our patients, it's not only the cause of liver transplantation, but a lot of our transplants that are not transplanted for steatotic liver disease develop de novo steatotic liver disease that may progress to steatohepatitis. It is at a lesser rate, lower rate than recurrent disease, but they also progress post-transplantation. And this is understandable because all our transplant recipients, they have an increasing rate of metabolic complications post-transplantation, particularly in liver transplantation, increasing rates of obesity, increasing rates of diabetes and dyslipidemia, and arterial hypertension. And if we look at the number of these risk factors, they really increase substantially at 5, 10 years post-transplantation. And many of our recipients have 2 or 3 of these risk factors, such that they have increasing Framingham risk scores, they have decreased renal function, and all of this is, generally speaking, not adequately controlled after transplantation. And there are many studies that show that they're not adequately controlled. And so we need to prevent this complication as much as we can, modifying particularly our immunosuppression. So this was our patient. As you can see here, the creatinine levels increased over time with a decreasing eGFR. LT, except for a couple of flares, really seemed to do well with normal transaminases in the long term. Gamma GT was, generally speaking, in the top level of a normal range, which is very typical of steatosis in the liver. And the patient developed all the metabolic complications with glycemia, hypercholesterolemia, and hypertriglyceridemia, typical of these patients, despite the fact that if we look at the immunosuppression that we utilized and following the guidelines published by many societies, such as the International Liver Transplant Society, they recommend double immunosuppression with mycophenolate. And we used once daily tacrolimus to adjust levels around 710, so avoiding over-immunosuppression in the first month, and trying really to reduce immunosuppression as much as we could by the 6th and 12 months post-transplantation, and try to decrease even further if liver function values were normal. We maintained mycophenolate due to kidney dysfunction so that we were able to reduce further calcineurin inhibitors, tacrolimus, and we did not utilize steroids to avoid the metabolic complications associated with steroids. So this is the data that shows one of the examples of the study showing that it's very important to avoid over-immunosuppression, particularly the first month after transplant, because these levels lower than 10 are associated with reduction of the risk of renal failure by half. In terms of optimizing cardiovascular risk factor post-transplantation and reducing the risk of death due to cardiovascular complications, there are many ways to do such, but one of such factors is really to optimize immunosuppression. And the guidelines suggest that we need to avoid steroids, as we did in our patient, but we also should use other drugs that have not that many metabolic complications, particularly use more often mycophenolate, such as we did in our patient, reduce calcineurin inhibitors levels, such as we did in our patient, and perhaps use mTOR inhibitors. However, this is associated with dyslipidemia, which may also impair outcome in this type of patients. So this is the evolution of the TAC trough levels and dosing in our patient. As you can see, we decrease the dose continuously after transplantation, but it's interestingly to note that intra-patient variability of tacrolimus was quite high, moving from 9 to 1, from 1 to 7 nanograms per milliliters, potentially explained by lack of adherence. It's difficult to know sometimes, but it could also be related to the fact that the liver function was not normal in this patient, which was developing cirrhosis. And you know that the metabolism of calcineurin inhibitors is done through the liver, and this may have impacted the trough levels that we achieved in our patient. So I will now move to a second case to illustrate the second kind of problems that we are witnessing in liver transplantation, and this is the increasing number of patients undergoing transplantation for expanded hepatocellular carcinoma. This is a man that had HCV alcohol-related end-stage liver disease and that developed a hepatocellular carcinoma with preserved liver function. The patient also had portal thrombosis treated with heparin, and the patient was waitlisted because of this hepatocellular carcinoma that was initially within Milan. However, while the patient was waitlisted, this tumor progressed out of Milan, and the patient had to be dropped out from the waiting list to be treated with chemoembolization, radioembolization, and then finally, once the patient was downstage to intra-Milan for 6 months, he was again waitlisted for transplantation. Transplantation had no problem, no surgical complication. Again, we use mycophenolate, dual therapy with once daily tacrolimus, and we use prophylaxis against HPV reactivation because the donor was anti-core positive. We had several problems post-transplantation. The first one was recurrence of hepatitis C, which is really no longer a significant problem because we do have new antiviral drugs that are used after transplantation very easily with almost no problems of drug-drug interaction with our immunosuppressive agents, and the patient reached sustained virological response. Portal thrombosis did not recur post-transplantation, and heparin could be stopped. In terms of the cancer, though, the patient in the explant had a solitary nodule which was greater than 2 centimeters, no vascular invasion. But when we calculated the retreat score, which is the score that we use to predict the risk of recurrence, the risk of recurrence was relatively high at 30%, and so we continued monitoring recurrence with a CT scan and MRI every 6 months for 5 years. This is the evolution of the tumor alpha-fetoprotein marker, which decreased from 105 at time of transplantation to 1 after transplantation. And the levels continue to be normal after 4 years post-transplantation. Unfortunately, the levels started increasing, and the CT scan showed a recurrence of the liver cancer, which was treated with sorafenib, and fortunately a progressive decrease in the cancer marker for 1 year and a half. So the key point here is what to do in terms of immunosuppression in the patients that we transplant for cancer, now that we are expanding our indications in terms of hepatocellular carcinoma. And there's data from both animal models, but also from humans, that really demonstrate that a high exposure to CNIs is an independent risk factor of HCC recurrence, particularly the exposure to trough concentrations of tacrolimus greater than 10 nanograms per ml in the first month is independently associated to recurrence independent of other factors, and in fact is considered one of the strongest factors in terms not unrelated to the tumor itself that may be modified to decrease recurrence post-transplantation. This is an interesting recent study with a large number of patients from several units in Spain, showing that the cumulative exposure to tacrolimus is associated in the mid-long term not only to recurrence of hepatocellular carcinoma, but also to the development of de novo tumors. And if you minimize calcineurin inhibitors and immunosuppression overall, this risk is reduced substantially. So there's also the idea that there may be immunosuppressive drugs that can have also, in addition to immunosuppressive properties, anti-oncogenic properties, such as mTOR inhibitors. And we had a lot of enthusiasm with this drug. Unfortunately, the only prospective randomized clinical trial that was published several years ago, that took many years to finish with Tacrolimus-based immunosuppression compared to non-Tacrolimus-based immunosuppression, did not show a benefit in terms of recurrence of hepatocellular carcinoma and overall survival. And we were really sad about these results, but there have been in the last 10 years, at least I would say 6 systematic reviews with meta-analysis. And all of these studies, despite their heterogeneity, despite their inclusion bias, they all really have the same kind of conclusion remark that they use mTOR inhibitors if it is associated with lower doses of calcineurin inhibitors, is associated with lower rates of hepatocellular carcinoma recurrence, and overall increased survival. So really the key factor is to use these drugs to reduce the doses, and if we can stop calcineurin inhibitors. In addition, there's data showing that there's increased survival if we use once daily tacrolimus compared to twice daily tacrolimus. There are not really many prospective randomized trials, but they're very small. But there's this large study from the European Liver Transplant Registry that compared graft survival of 3 years of treatment with TAC once daily versus twice daily, using a propensity score matched analysis, and showing that these patients, also patients only with hepatocellular carcinoma, they have a better outcome. And in fact, if we looked at this prospective 10-year follow-up study where patients were switched after first initial phase of dual of BID tacrolimus, they were switched to once daily tacrolimus, and then they were followed for 10 years. And these patients had a significantly better quality of life, they had a better adherence to treatment, and they had a lower intrapatient variability, which, as we just heard from the kidney transplant arena, is associated with better immune-mediated complications, but also with better results in terms of recurrence of cancer, and particularly in terms of kidney dysfunction, which in liver transplantation is very important to reduce cardiovascular complications in the long term. So this is the evolution of immunosuppression in our patient. We use once daily tacrolimus. We try to reduce as much as we could the trough levels of calcineurin inhibitors. We use MMF. We did not use, unfortunately, mTOR inhibitors from the beginning. We tried to use it at the time of recurrence, but unfortunately the patient did not tolerate mTOR inhibitors, and that's the negative part of mTOR inhibitors. It's really their side effects. So our patient developed proteinuria, and we could not continue mTOR inhibitor in our patients, but we reduced as much as we could calcineurin inhibitors. So what is personalized immunosuppression? Shall we do it? Well, we try to do it. We try to do it, as I mentioned now, in metabolic syndrome, avoiding steroids and reducing calcineurin inhibitors. We try to do it in cancer, particularly introducing mTOR inhibitors and avoiding high doses of calcineurin inhibitors. We try to do it in many other settings. And this is really what we typically do. It was just commented before. Typically, our immunosuppression is MMF with calcineurin inhibitors, mTOR inhibitors if there's cancer. We'd use interleukin-2 receptor antibodies initially. If we have kidney insufficiency, we try to avoid steroids as much as possible, except for the patients with immune-mediated liver transplant indication. But the key point, I would say, is that really drug exposure is a poor indicator of immune suppression. And overall, we really do not know what is the net status of immunosuppression in our liver transplant population. There are now new biomarkers that are being developed, cell-free DNA, microRNAs, but so far they need to be validated to be used in daily clinical practice. And so I'd like to summarize that we have really improved long-term outcomes, but this long-term outcome is still hindered by recurrent disease, malignancies, cardiovascular disease, infections, and chronic kidney disease, which all are in part associated with over-immunosuppression. So individualizing immunosuppression and managing adequately the risk factors that can be modified may help reduce the burden of this complication. It's important to reduce intrapatient TAC variability, which may help improve outcome, as we heard also in the kidney transplant population. And we know that particularly adherence and TAC formulations are related to intrapatient variability. And so now, at least in our center, we typically use once daily formulations, because we do believe that they are beneficial for the patient in terms of reducing intrapatient variability, enhancing adherence, and overall improving outcome. Thank you.
So what are the key takeaways from the last segments that we have? First of all, let me thank Dennis and Marina for their very insightful segments. This has been a terrific walk through the clinical and real evidence using conventional and newer formulations of tacrolimus for the prevention of rejection in liver and kidney transplantation. Before we go, though, I'd like to share some thoughts and key takeaways from today's session. So, number one, individualization of immunosuppression is key after kidney transplantation and liver transplantation because of individual immunological risks, IPV, and comorbidities. Number two, once daily tacrolimus formulations may benefit transplant outcomes by reducing IPV and enhancing the timing and taking adherence of the patients. With that, I'd like to thank Marina and Dennis and thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.